Okay. Everyone, we'll go ahead and get started with the next section, which is going to be on metrics. So again, I'm Bob Truog. I'm a intensive care physician at Children's Hospital, and I've worked with Dan Brock in the ethics program at the medical school. And so for this session, we have three experts in how to measure and improve quality in medical care. And you might ask, well, what does that have to do with measuring a company's global health footprint? And so I think what this session is going to ask us to do is to look at an area where metrics have been developed over a number of years and where the science is fairly advanced and where we have experts in the field, and then think about how we're going to build bridges to an area that's less defined, such as measuring the global health footprint of companies. And so our three speakers are going to be Joe Ross, right? I'm going to introduce you first, and then I'll have you stand up here. So you're an internist at the Yale School of Medicine, where all of your, much of your research anyway, has to do with measuring quality in healthcare, pharmaceutical industry, medical devices, those sorts of things. Lisa Hirschorn is our next speaker down the list there. Lisa is an infectious disease specialist at the Brigham, specializing in HIV/AIDS as well as other things. For our purposes today, she's Director of International Monitoring and Evaluation for Partners in Health, which we all know is a global organization dedicated to improving health around the world. And then finally, Paula Wilson is the CEO of Joint Commission International, the international affiliate of Joint Commission. And certainly for those of us who are physicians in the room, we're very familiar with the important role that the Joint Commission plays in accrediting, consulting, education here in the United States. And I know from my international work that Joint Commission International is a highly sought after accreditation standard. So I guess we're going to, now are all of you going to be using slides? I wonder if we should just pull our chairs around so we don't get crooks in our neck from looking over. Is that all right?
Yep. Sure.
Okay, terrific. So I actually asked myself the same question. What was I being asked to talk about here? And so I did my very best to create a presentation that I think will be useful, and I'll try to keep my comments to 5 to 7 minutes, but I'm sure I'll just end up talking fast. But I'm happy to speak and answer questions and talk about some of the work we're doing. So the relevant disclosures, just to make everybody aware, is that I receive funding from the Centers for Medicare and Medicaid Services to develop and maintain performance measures that are used for public reporting, and I sit on a scientific advisory board. That's kind of irrelevant. So the important thing, we develop performance measures to measure quality. So just to start with the central definition, the Institute of Medicine defines quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. This is Avitas Donabedian, who is one of the founding fathers of quality and how it's structured. And this is a sort of concept of what it is. Like particularly in medical care, you have three pillars of quality. There's structural elements, there's process elements, there's outcomes. The structural elements are things like equipment and personnel for care. And this is things like having an electronic medical record or having enough nurses to take care of your patients. Then there's these processes or the activities of care, like giving the right prescriptions to a person when they're being discharged from the hospital, assessing whether they're a risk for falling. And then there's outcomes of care, and those are the sort of bread and butter, the mortality, functional status, symptoms, harms, and that's what our group really focuses on. We develop outcome measures of care, and we really focus on the experience of care, cost, satisfaction, as well as the clinical endpoints that we believe are most important for patients, the idea of mortality, functional status, symptom burden. So this is just a slideshow. We have about 10 years of experience now developing performance measures for Medicare. We've developed statistical models that are used with administrative claims data to estimate hospital performance with regards to mortality rates, readmission rates, complication rates across a variety of conditions. And this is just a very simplistic diagram that CMS uses when they report their data for individual hospitals. This is actually Yale. And you can see up on the map, it gives you the percentage points of what the actual readmission rate is, what the rate is for that individual institution, and here it's 20.6%. It tells you if it's different than the national average, which is that lavender bar. And then you can imagine a hospital that's on one side or the other gets identified as a high performer or a low performer. And what's that information used for? Well, it's used for hospital advertising. What else would it be used for? No, that's not exactly what it's used for. It's this is a conceptual model that is silly for me to present to experts like you here. But performance measurement is really about promoting transparency. It's about facilitating decision making by patients, physicians, and particularly purchasers. It's used to provide assessment of health system function and delivery, and increasingly it's being used for accountability, incentivizing improvements through public reporting and pay for performance. And you can sort of step back and think, well, these are all the different things it's used for, but what would patients want, right? Patients want performance measurement that's aligned with their patient care priorities, that accounts for their preferences, and that the measures are meaningful. Can the measures be used to figure out which physician or which hospital is better? What do physicians want in turn? They want fewer measures because it's a burden. They want fair measures because they think their patients are sicker. They want the same things in terms of alignment with patient care priorities, right? But what they really want are actionable measures, right? Are there clear ways to improve? Are there clear ways to address the deficiencies that are identified? But this is actually even a little bit different than what health systems want. They want all the same things, but they want the same types of meaningful measures that patients want, right? Because they want the measures to be really focused on important outcomes that promote innovation in clinical delivery, in clinical care deliveries, and measures that are rigorously designed, that they can be confident in terms of the assessment of actual performance. So I'm going to have to move through this kind of quickly, but this is just a general standard-setting document that was used. It's developed back in 2006. That's really about how statistical models could be used for public reporting. And you can see that they lay out 7 clear attributes that need to be there for the publicly reported measure to be considered, rigorous, right? And it's the idea of a clear and explicit definition of an appropriate patient sample, the clinical coherence of the model variables, what they're case mixing, risk adjusting for, sufficiently high quality data, but also timely data, so that people aren't getting performance measurements that lag 5 years after the actual care was delivered. They want a designation of an appropriate reference time before which covariates are derived and which outcomes are measured. They want to use appropriate outcomes and standardized period of outcomes for assessment. And they want application of an analytical approach that takes into account the multi-level organization of data, which is surprisingly rare in outcomes measurement. And then, of course, they want disclosure of the methods that were used so that people could, criticize the measure, as is often does, but actually just, fairly evaluate it. Let me just skip that. So then you get to this issue of, so does public reporting actually help? And I like this sort of schematic, like if you build it, right, they will come, right? If you start measuring, people start paying attention, particularly if it's CMS that's doing the measuring. And we know that, after CMS started measuring all these various things, when they started measuring structural components, those structural components improved. When they started measuring processes of care, all of those processes of care improved. And increasingly what we're seeing is now that they're measuring outcomes in care, those outcomes are improving as well. So it seems on the whole, and this is a very simplified slide, but that public reporting is effective in improving performance. And this is just sort of gets at the big picture pie in the sky. What is the promise of public reporting? And what I like to think is that ideally we can get to the point where performance measurement stops being about public reporting for patients, which I find it's just hard to navigate, particularly around hospital performance. But instead, that performance measurement is really about constructive improvement, right? And it's performance measures being used to support quality improvement. It's being used to facilitate shared goals of patient-centered healthcare, which are best outcomes at the lowest cost. And then it's being used to monitor for unintended consequences, particularly around variation in care, in order to direct resources and direct policy. So I did it. I told you I would talk fast, but that's my spiel. Yes, this is death panels. What else would it be?
Oh, good. I'm so glad somebody else is going to deal with getting it up there. I could burn at least 2 or 3 of my minutes doing that. So I had sort of the same response, which was I sort of said to Nir, thank you so much for asking me to speak. What am I supposed to be talking about? So he said, just talk about sort of what you do. And a lot of the work that I do now is actually international. So it's done very much in resource-limited settings where we really think very carefully the dollars that we actually using for measuring. And there's a thing that we always say, which is you should measure what matters. And so I've sort of said, what can we measure that matters? And sort of use that as the premise for the 5 minutes that I have. So again, there's probably going to be some overlap. You can sort of tell we probably come from the same school of thought, which is, the first question is why are we measuring in clinical care? And I'm perhaps a little bit less focused on public reporting than I am on sort of the day-to-day quality. And that's really to understand the difference between quality and reality. And that's the sort of quality chasm or the no-do gap, however you want to do that. But it's what's really happening, to identify areas of variability. And a lot of times in public reporting, it's focused on the negative outliers, but also looking at the positive outliers that often, for us, hold the secret of how to actually make things better. To hold providers and organizations accountable, not just to the donors or to the funders, but also, very importantly, to the communities they're serving. And then peer pressure through performance measurement, and it's definitely one of the things that's been driving public reporting. So some of it is pay for performance, but some of it is also, who is actually doing better, and potentially the role of market forces. And then very importantly is to identify areas for improvement, for particularly in areas of quality. I think it's also, though, important to recognize when we're talking about quality improvement that, and this is where we get very caught up sometimes, is that the first step has to be really what the last panel talked about, which is defining quality. So when people are talking about standards and norms, if we don't actually have them, it's very hard to actually measure quality, much less actually improve it. We're sort of talking here very much about the metrics, about measuring quality, but I think equally important, and this was a little bit about perhaps what public reporting is doing, or were people actually using the community-derived standards, is figuring out what changes are needed, doing it, and then checking to see if it actually works. So if we stop at the first two, that's where sort of public reporting stops. It's only if actually change happens. This you've just seen, obviously, the defining quality of care, but I actually like Deming's definition better, which is much quicker. It's doing the right thing right away. And it goes into this idea about, again, what do we know what is quality? Are people actually delivering it as they're supposed to, and are they doing it in a timely manner? So what do we measure in healthcare? And you've already seen these things from Donabedian. Again, you can sort of see there's a sort of common set of knowledge for structure, process, and outcomes. But we've actually added the customer-defined quality, which is sometimes lumped into outcomes, but we tend to separate it out because it really is a lot of times a different methodology, and it's often lost in the process. And then particularly at Partners in Health, because we're very much of a social justice organization, we talk about equity, when that's about the last mile. So if you are providing excellent quality of care to 90% of the population, but the 10% that are not getting care are the most vulnerable, the furthest away, the poorest, that's actually not quality of care. And so we consider to be equity as the fifth domain. So what are some of the pitfalls of measurement to drive improvement? The first is measuring what's easy to measure. So only looking, for example, at deaths that occur in a facility as opposed to deaths that are occurring in a community. Looking at process measures too much compared to outcome measures. And so we may be driving people to overutilize. Measuring outcomes that are affected by ascertainment bias. There was an excellent article recently about the pitfalls of using DVT prophylaxis, so prophylaxis for blood clots, as a measure of quality, and then they actually linked it to the outcomes of having a blood clot. And it turned out that the people that were had higher use of the prophylaxis actually had higher blood clot levels, but that was because they actually were much better at actually screening for it. So we have to be very careful that outcomes are not biased by people actually doing better at looking for problems. It's, if you don't look, does it actually exist? And then again, this idea of just focusing on process, which can result in overutilization. And there was a follow-up editorial which actually pointed out that probably a lot of the people getting prophylaxis for DVTs actually probably didn't need it, but people were actually achieving high values. Another great example of that is if we look at cesarean section rate, it's supposed to be between 5 and 15%. And if we just focus on that and not on maternal mortality, it could be that it is 10%, but it's not the right 10%. And so we need to actually measure a little bit more to really make sure that it matters in what we do. So The other potential pitfalls that we've seen is insisting on measuring what you cannot easily measure, and that's something particularly that I've run into a lot, where people want to measure things that will cost you about $200 to measure for each person, and we just can't actually measure that. Another example of that is maternal mortality rates. I'm giving you a grant for $20,000. I'd like to see the drop in maternal mortality rates. And anybody who actually measures maternal mortality rates say, you can't do it. It's actually quite complicated, and you're never going to see a difference. A lot of donors need a lot of education around that. Ignoring risk adjustment, and there was a classic example from New York when the cardiac surgery mortality rates were first put out, that disparities in race-associated access actually increased. Because people were saying, oh, you're not risk adjusting, I'm going to not take care of the people that are at higher risk of having poor outcomes. And then ignoring another measurement that's already underway. So people come in and they say, oh, we want to measure how good your prevention of mother-to-child transmission is. We want you to collect all of these new data. And it turns out that probably every single site in the country, in most of the countries, actually are already measuring that. And finally, just measuring and not doing anything with the data. So this is the typical monitoring evaluation loop, and this is just measuring. So what you can see is there's a huge amount of data that's going up, there's very little coming down, nothing's being used, and a lot of data is not actually even being used. This is actually the model that we have at Partners in Health, which is called M&E for Integrating Monitoring, Evaluation, and Quality Improvement. Data still gets reported. More feedback comes down because we've capacitated the national program or the donor. But most importantly, the vast majority is actually being used internally or with Partners for Quality Improvement. And I think only when we can get there, and we have more than enough sort of data that's already being used to understand what matters, and then how do we actually make it matter. So what can this teach us? Measure what matters, measure what can be measured, measure what can be changed, be careful about unintended consequences, and then finally, do not just measure. Thank you.
Okay, good afternoon. I'm Paula Wilson, CEO of Joint Commission International, and this is something a little different. I have 3 slides, including this one, and I speak very quickly because I'm from New York, so I'm sure I'm going to fit more than anyone into 7 minutes. But this is I'm going to actually give you a very quick overview of a system, a rating system, an evaluation, and accreditation system that works pretty successfully, and that is the one that's used, and we mostly do hospitals outside of the United States. Most of you, I think, or many of you are familiar with the Joint Commission in the United States. It's been around since 1951, and it is the largest accreditor of hospitals in the world, and we are the largest of the accreditors outside the United States. Our mission is really safety and quality oriented, and I mention that because one of the questions that NIR has been raising about, what can organizations like JCI do to help with things like workforce distribution and access to care around the world, and that's not necessarily within the purview of the mission of a nonprofit organization such as ours, but we are an influencing factor in healthcare internationally, so it's a very provocative question that he's asked. But just a real quick flashcard on what we do. We started doing this in 1999. Now, the Joint Commission's been accrediting hospitals since 1951, but it wasn't until 1999 that in the early 90s, hospitals started to go to them from outside the U.S. To be accredited. And it was a function of the growth of globalization and the growth of economies, and there being a lot of hospitals outside the U.S. that are becoming very high level in terms of the care that they delivered, and they wanted to have an external validation and an external accreditation of the work that they do. So as of today, about 600 hospitals, mostly centered in 3 regions of the world, have been accredited by Joint Commission International. Probably about 500 hospitals and 100 other ambulatory or other types of organizations. And we're growing at about 20% a year, so we're not a huge company in terms of revenues, people, and even impact. But we're really big in terms of brand. It's rare now that I don't meet with people who have some presence in the international community, in the international health community, that have not had either heard of us or know about us. And it's a very interesting phenomenon for a relatively small organization. We do business in the Middle East, Europe and the Middle East and Asia Pacific. We have a sprinkling of hospitals in the Caribbean and into South America. And the fastest growing right now is the Middle East, particularly United Arab Emirates and Saudi Arabia are areas that have really taken up the cause for accreditation and have become rapid growth areas for us. And we're seeing the growth increase in China recently as well. We do use a different set of standards. They're international standards, and they are the same standards no matter where the hospital is located. So we don't customize according to the local country, but we do customize according to local custom and culture. We try to be extremely competent in cultural competence and being sensitive to the needs of particular organizations. For example, we're in the midst of looking at whether or not should we have some process standards around traditional Chinese medicine. It's not a comment on whether or not we believe it's effective or it's a viability. We don't do that with any types of medicine. But we get concerned with things like there's a lot of roots and plants that are used in traditional Chinese medicine. So our interests are what's the process of getting those things into the hospital and how are they stored? And are they date stamped like we would with any other kind of pharmacological intervention? Why do hospitals pay a lot of money to be accredited by JCI? Well, it's a competitive environment out there, and so the big hospitals, investor-owned in many instances around the world, they are looking to bring more patients in, and they want to show that they are the best available in a particular region, in a particular country, and they, to some extent, want the bragging rights that does bring in some of the medical travel that Nir has referred to earlier today. We find they're very competitive among themselves. They want to keep up. They're very committed to quality. It's a lot of work. As I mentioned, it's time and it's a lot of work to be accredited. We go back every 3 years and we have a lot of intermediary kinds of discussions with them and reporting with them. So it takes time, it takes people, it takes capital. And so they're committed because it has a better outcome for their patients. And there's also a driver for this in that there are medical travelers, and I call them travelers, not tourists. I think they got the name of the tourists because a lot of Americans went to Argentina and to Thailand for things like plastic surgery. But today, with the emerging middle class in places like China and other parts of the world, people who previously had no discretionary income to spend on things like healthcare are looking for high-quality providers to get that care. So there are a lot of people traveling out of Eastern Europe, out of the Middle East, within Europe, around Asia Pacific, and they're looking for high-quality providers to get what would be not plastic surgery, but to get needed health care, needed medical care. And then, so I think that between the interest of those travelers and then the competitive environment among these hospitals have been two of the key drivers for the hospitals that we do business with. We have a very rigorous process in terms of what we do when we do the accreditation. So typically what happens is it's over a course of a 5 or 6 day engagement, depending on how big the hospital is. And we send a team of surveyors who go in there and rate them depending on how they're doing on all the different standards. We have a deliberation around it, and then we either make a decision that they become accredited. In many instances, they have to try again within 6 months, and in about 5% of the time, they don't make it over the line, and they have to kind of start all over again. But most hospitals, by the time they've come to us for an accreditation, have done a lot of preparation. And as we have gotten so much bigger outside the U.S., a lot of organizations know what it's about now. The first few years were obviously very different than today. And we use measures very actively. We require measures for being accredited and creating libraries of measures internationally. So I think I'll close there and be available for any questions, but I think that there's two aspects of what we're doing. One is that we're a rating system and an accreditation system that works and has worked for a long time in the U.S. And the other is, to what extent does an organization like JCI have to correct some of these imbalances that we've been talking about? And it's an interesting conversation, and one that I'm not sure where I sit on it. It's very interesting, but thank you very much.
Thank you. A lot of overlapping areas of expertise here. Hope we can take advantage of all you know about how to measure and improve quality in healthcare and talk about how we might extend it into this realm that we're talking about today. Yes, let's start down here.
Aidan Hollis. Just a quick question on whether there's actually any good empirical evidence on whether measuring outcomes changes outcomes. Joseph, you referred to basically saying, well, we started measuring outcomes and then there was an improvement. So, well, there's an assumption that measuring outcomes had an effect, but we don't know whether outcomes would have improved anyway. So you'd really need to do some other kind of study to figure that out.
Right, so
and I think the same thing sort of applies for JCI. I'm not sure whether there's, I don't know whether there's evidence on.
Very little.
Okay.
So I was deliberately simplistic when I put up the slide. There's a lot of evidence, obviously, that if you measure activities of care, that those activities go up. The evidence on whether or not public reporting outcome measures in itself improves outcomes is a little fuzzier. There's some studies that suggest it does, some studies that suggest it does not. Others where there's perverse incentives around the idea of whether pay for performance is actually what's driving the improvement. And it's hard to obviously disentangle all the other things that are happening at the same time in terms of developments of new treatments and ways to deliver care and all of this. So I don't think it's a slam dunk, but at the very least, it drives attention to the outcomes we think that are important in order to promote innovation.
Thank you. My question is for Lisa, and I'm particularly interested in hearing about your experiences wearing your Partners in Health hat. And the reason is that I serve on the board of Doctors Without Borders, which has been struggling. There's a very live internal debate across the organization on how to share, if at all, any kind of information regarding the quality of medical programs. And this has been a long-running debate, and various people are arguing for or against to improve patient accountability to donors, et cetera, et cetera. And it would be great to hear what a sister organization thinks about that issue. But more related to the topic of this conference, that debate has now been pushed forward a bit by the fact that Charity Navigator, which many of you may be familiar with, ranks charities on a scale of 1 to 5 stars, has announced that it's going to begin implementing I think an impact-based criteria for its assessments, whereas it used to only measure, I believe, outputs. I'm not exactly sure all of their criteria, but and this system, Charity Navigator, has a huge impact on, well, we believe it has a huge impact on fundraising across the country. So I would really be interested in hearing your thoughts on, and of course for the whole panel, but I think particularly because of your PIH hat, you'd be well placed to respond. How can organizations respond to this kind of new demand for accountability and transparency regarding quality of programs in a way? And what are the particular challenges that may come up, particularly for organizations working in difficult contexts that might be insecure, that might have very little infrastructure, where quality indicators might not look like what we want them to look like in this country, and all of the challenges that are raised by working in an international context? Thanks.
So that's a really excellent, both of them are really excellent questions, and we certainly are struggling with them. I'm going to take the second one first, because that's something that we've been sort of deeply engaged in, both through Charity Navigator as well as a number of these other ones that want to measure impact. And we've had some very active discussion and really trying to educate as we push back donors in terms of, where somebody says, literally, we will give you, 20,000 bed nets, and we want you to measure the impact on retention and care. We said, oh, that's great. We can tell you how much it'll cost to actually measure that retention and care, because we have a good sense but not a perfect sense. And if you want us to really report it, we really want to make sure it's good, and it will cost you $5,000. We can give everybody how much it is. And they say, oh, no. We spend all of our money on nets. We said, oh, well, actually, we spend all of our money on care. So it's really, I think, a debate, and we're really trying to educate donors that they need to actually pay for the data, because it is data we should know. We should know, does it actually work with that? And I just want to sort of do a quick shout out to the Doris Duke Foundation, which is one of the only places that actually gave very large grants, both for population health improvement with actually enough funding to measure impact. And it was a very unique grant. Their board unfortunately didn't refund it after the first round. So what we've tried to do is sort of utilize some of our academic affiliations here, so that we actually have people who really are experts in maternal mortality and can really sort of push back and say, here's what we can measure, here's what we can't measure. So that's number one. The second is we're really trying to do modeling. I'm not a huge modeler fan, but for things, for example, like LIST, which is a tool that in which you can put in sort of some routinely collected process data, you can actually come back and say, here's what the impact might be. And so we're actually trying to utilize models for that, although I don't know how transparent necessarily people are about sort of the confidence intervals about what we can actually say. And then we've actually tried to work very hard with governments. So, for example, in Rwanda, we've actually gotten the government to help us oversample in our districts, and we're able to do that. But again, we're in a very different situation because we aren't crisis driven, and so we do have longitudinal type of things to be able to do. So I think it's actually quite more difficult for you. And I know I was talking to somebody, I think from that organization, it could have been from another crisis organization, where they said, oh, we want people to do post-operative wound infection. And they said, well, up to 30 days. They said, we have no idea where people go after 30 days. So I think it's a lot of it's going to just take kind of pushing back and educating. In terms of the transparency, we are sort of, as we get more and more confident with our numbers, we actually are putting more and more of them out there. One of the constraints we have is because we're always in a public sector, they're not actually our data. So if we want to put something out from Rwanda, we better go and talk to the Ministry of Health and say, here's what it is this okay with you? And that includes putting things up on our website. So we're trying to do it more and more, but really trying to equally be respectful of the true owners of the data, which are not actually us, but the ministry.
Please.
I know it's kind of lame to do a redo of an answer to a question, but if I could come back to the point you made about the outcomes. Sorry. I would be remiss if I just didn't add, the science of quality measurement itself is advanced an incredible amount. I think actually the point you're getting is the science of quality improvement is not nearly as far along. And so measuring outcomes, which we believe to be important to patients and meaningful, the science of actually how to improve outcomes is not nearly as developed. And so this gets back to the idea that was raised around positive and negative deviance and learning from higher performers and low performers and sort of going into their environment, trying to figure out what they are doing differently. But that's sort of where we need to go from here. Now we have good measures, and it's a matter of figuring out how to actually improve the care. So sorry to tack on.
So actually, I can add one other thing which we do. Sorry, this is sort of
We'll just keep
you've
going
gotten on
back
my
and
we shouldn't have to measure outcomes on things that we know are effective. So if we do something and you increase measles vaccination coverage from 50% to 90%, you really have to show a drop in under 5 mortality. Is anybody going to say to you, no, that was a bad thing to do? So the other thing we're trying to do is to at least get donors to understand that there are some things for which process really is good enough, and then there certainly are other things that we do actually have to figure out how to measure. As we say in our thing, so what? So we sort of measure how many, how well, and so what? How well is the quality? So what did it actually make the difference?
I'm Ole Norheim from Norway, visiting professor at the Department of Global Health and Population. So I have a question to the first two presenters, Joe and Lisa. So this morning we heard Josh Salomon talk about the burden of disease measured in terms of disability-adjusted life years. You didn't talk about it, but how would you think about using DALYs as an impact measure?
I don't know if we would use it as an impact measure. We certainly take into account burden of disease when we're identifying conditions for measurement. So when we're trying to make a decision around what conditions, what diseases that a hospital is taking care of or that physicians are providing care for, we are deliberately targeting conditions for which there's a high burden for disease. I don't know if we're explicitly measuring it using DALYs, but it plays a role.
Yeah, we've used it, but more really in our my own. Sorry. We use it in some of the more things when we're going into more details in terms of some of the academic publications that we're working on. We tend to not use it as a general measure, in part because it also puts into some judgment about, well, what's your expected life, what is your life expectancy, and then how much is that actually worth, and then should we actually be doing in terms of life years. And so we're playing around with it in the same way that we are actually starting to look at cost, not cost effectiveness, but actually the cost of the care that we're actually delivering. It's probably something we do need to do going into the future, but right now we're just trying to be able to be as confident as we can with fairly wide confidence intervals around what we're actually measuring.
Thank you. Can you hear me? Yes. I'm here actually to ask for help. I really appreciated the sessions this afternoon. I missed the morning. I am a physician with the Harvard School of Public Health and the Department of Environmental Health, where we train medical doctors in occupational environmental medicine as a residency training program and fellowship. I'm also an internist and had previous life as an occupational hygienist, which is primary prevention in the factory floor, workplaces, and having to do with the environmental impact. And prior to that, I was co-founder and co-director of an NGO that was Asia Pacific based. I lived and worked over there and have a lot of ties with the labor and environmental activist groups. So I'm particularly interested in the work of Partners in Health, Doctors Without Borders, and that sort of thing. So perhaps we could corral for 5 minutes after the meeting today. That would be very helpful. But in my work looking at multinational activities and visiting consulting for companies as well as for NGOs over the last particularly recent years, I've seen that there is a tremendous dearth of talent. There's very little capacity at the professional level to deal with the issues of climate change, of pollution, of work practices that are not favorable to labor conditions, or to the local community environment. We know, for example, here in the United States that the OSHA regulations are really tough to implement, the OSHA standards. And if you look at a cross-section of the OSHA standards, you can see that the requirements, for example, for doing medical surveillance are very different from standard to standard to standard because they're developed in a different process, typically by lawyers and economists. We know that the problems are so dire, and the ILO, for example, has said that they believe there's about 1.1 million deaths per year due to occupational illness, let alone injuries. And so since 1956, the Asia Conference on Occupational Health has been meeting every 3 years, and in the 50 some odd years since then, things have gotten worse. So we pulled together a conference in Hong Kong for the first time of grassroots physicians, nurses, hygienists, labor activists, NGOs from around the Asia Pacific region, and we included South Africa because they're very progressive, and I've seen what they're doing there. But the idea now is to really try to figure out ways where we can partner institutions like this one, or Yale, or Stanford, any other that might have sort of clout by name, but also a lot of good professional experience, to using the internet, and we worked out a mechanism for this, to actually train and certify people so that they can start making diagnoses and certifying worker comp cases so that these people get appropriate diagnosis and care. And they stop doing mass lung lavages for mine workers and construction workers. So I'm going to leave it there for your thoughts, but I think the important thing is while I believe in the metrics, I also believe that time is very short. And if we can get around some of the restrictions that, for example, the ACGME applies to training a doctor like myself, such that we could export this training across international borders and quickly train others, including primary care physicians in occupational environmental health, that would be great. Thank you.
So I'm going to sort of comment just on probably a relatively superficial level about the idea of capacity building sort of across countries. And I think that as opposed to a couple of years ago, there's actually a lot of innovation that's happening with that between, sort of some of the Coursera, edX, MOOC kind of things, as well as there's a very interesting model that was done around hepatitis C in Arizona that's now sort of gone national, and I think is actually doing some international work, which is based on a combination of skills building, case-based learning, and ongoing coaching and mentoring, which can be often done from a distance. In Mirabelais in Haiti, for example, we don't actually have a radiologist, but we do have the ability to actually actually transfer the images, and we're starting to have the people here mentoring the physicians who are actually reading the CAT scans and things like that. So I think that there's certainly, seems to me a moment of opportunity where that's increasingly recognized. I think there was just one of the first, I think Berkeley even here, School of Music is giving some sort of distance, like, degree in music, which I find a little hard to understand how they're doing that. So I would just sort of encourage you to probably not even this community, but the community of people who are sort of innovators in education, who may be able to figure out what some of the approaches that are being done. But there's I think I've seen some really fantastic things, exactly what you're talking about, which is taking a specific skill and figuring out how do you actually transfer that. And the only thing I would say is you can't do it with an online course. It is going to need some kind of coaching and mentoring, particularly as it goes towards patient diagnosis. And then some of the online communities like GHD Online, which actually has a closed community that's actually a clinical exchange. So if I see a patient with a strange rash, I can actually post that information with the rash and get experts who are part of the community to actually comment on it. So I just encourage you to look in that particular area of expertise.
So I have a broad question. We've been talking about some rating systems that are only focused on outcomes and some accreditation systems that are more focused on process. I'm wondering if there's any sort of rules of thumb for thinking about when it might be better to focus on outcomes versus process, or some combination thereof. And I have a hunch that one thing we might want to think about is whether there's consensus or sort of contention. So where there's consensus on desired outcomes, you might be able to measure them, and where there might be contention or less definition, say global access issues to medicines, you might focus more on process. But are there other things that you can think about?
Do one of you guys want to start?
Well, maybe let me just follow up on the question a little bit, and specifically for Paula. The Joint Commission in the United States is an extremely powerful organization when it comes to controlling and setting the direction that hospitals move around almost anything. If it becomes an issue for the Joint Commission, it's an issue for those of us in the hospitals. And I imagine that Joint Commission International is very similar in that regard. So, and it's a combination of process and outcomes, and yet it enjoys tremendous clout. So when we think about when we think about the global footprint, if you will, of companies, I mean, are there any lessons to be learned about how one acquires this degree of influence and power in the field that can cross over into this other area?
I think the markets are really different. I think in the United States, it's mandated. If you're not accredited, you don't get paid. And so that obviously is a very different culture than it is outside the United States, where it's a voluntary decision. But I think that, so we have to be a little more careful in the international side to not be too punitive and too that finger in your face, which we're not doing domestically anymore either. We've actually tried to change the tone and culture of the Joint Commission, because you really don't get a lot done if people are so afraid when your surveyors are coming in and all they're doing is hiding all the bad stuff. That's really not helping patients at all. So we've really gone way out of our way in the whole global company to be much more engaged, much more what Lisa was talking about, coaching and mentoring and teaching, has a much better impact in terms of outcome for patients. In terms of process versus outcomes, we do both, obviously. We really focus on process. On the international side, probably more so. Most of the hospitals, of the 600 now, there's probably only 200 that have had more than 2 or 3 surveys. So today there was probably a survey of a hospital that's never ever been surveyed, has never had an external evaluator. So we really are focused a lot on the process at that point, about how does a patient move through this organization. And then after they've been accredited once, that's when we get more into the measures, which is where we get much more about the outcomes in terms of what's really happening to patients, what are your infection rates, and things like that. So for an organization like ours, we use both, and it has to do to some extent with where the organization is. Where the country is, to some extent, influences that as well, in terms of the external environment that's going on. So, but you need to have both. But I would say the accreditation process even domestically, is still a little more process-oriented than outcome. Don't say anything to anybody in Chicago that I just said that, but if you look at the standards, it's much more of a process. How did the work get done, and how did you do it without hurting somebody in the process is a huge thing that we focus on.
I think, it really goes into this issue about also what can you measure, to start with, and what can you feel good about. I mean, one of the things that we see in quality improvement is usually the first bump in improvement is actually data quality, and
Right.
so I think the first question is, how confident you are that you can even capture it. Measuring something as simple as facility-based maternal death seems like that should be a fairly easy thing, except it turns out if you go back and look, nobody wants to own the death, and so sometimes the woman gets put into the ambulance, and then, nobody would say, oh, she died en route. So I think it's a question about what can you measure, and then the second thing is how closely you can link the process to the outcome. So the further away that gets, probably the less validity you have about measuring the process opposed to something going to there. But I think the other thing is to rather viewing it as static is to view it as something that progresses over time. And an example is, we might first look, do they even have a blood pressure cuff in the delivery room? And then the second is, okay, they have a cuff, great. Are they taking the blood pressure? Okay, great. If they take the blood pressure and it is elevated, are they treating them for preeclampsia? So if you started just saying, are they treating for preeclampsia, and the answer is they don't even have a blood pressure cuff, it's not actually a very valid measure. So I think the idea is to also view that you can have hospitals or facilities that actually progress their way through to the sophistication of actually getting to the point of measuring the outcomes.
Okay, yes. Yeah, Nick Schuckle at optimalleadership.org. Yeah, great presentations all of you made. I wanted to kind of take a step back and look at the bigger picture here in terms of the footprint. When you start looking at ratings for hospitals, like U.S. News is the big, that was the big one that people look at. And a lot of the stuff you mentioned, of course, is important to take a look at what goes on in the hospital once you get the patient in there. But from a paradigm standpoint, I mean, our system right now isn't really, it's dubious that it's a health care system, as Dr. Dean Ornish even points out. It's more of a death care, disaster care, drug care. It's the system itself is kind of a disaster. And so the interesting question, I think, ethically, that really begs the question is, what exactly are hospitals doing, or rating systems doing? That's the bigger question of prevention. What are what are their obligations to their community, and keeping patients out of the emergency room in the first place, or keeping them from, having the heart attack in the first place, a stroke in the first place. And second, once they get there, let's take a look at blatant cases of hypocrisy like McDonald's or Burger King inside of hospitals. The hospital food itself is a catastrophe. I mean, we're creating, as Dr. Esselstyn calls it, hospitals are temples of disease. They're not temples of prevention or care. And so what are we doing to get McDonald's out of these hospitals? And how can we use global, ratings, so to speak, to, blame and shame, so to speak, hospitals to do better, number one. Number in prevention, once you get in there. And third, you look at hospital food. We know Harvard School of Public, Dr. Walter Willis made a big deal about red meat. I mean, the studies are just overwhelming amount of data. We should really be getting rid of it for the most part. And why are we serving that in hospitals all across America and literally creating, vascular damage while the patients are there? We're supposed to be healing them and caring for them. Why are we making them more sick? Not to mention the other dubious dietetics practices that, I'm sure many of you are aware of and observe. So if any of you can address the bigger question of the paradigm prevention and how to exactly get ratings to address to do literally, from a Bentham standpoint or Mill standpoint, the greatest good for the greatest number. And I don't think that happens in the hospital. It happens in the prevention paradigm for the most part. Thank you.
So I can start by saying a word about this. I mean, so first of all, here we are surrounded by 4 different tertiary care hospitals, quaternary care hospitals, right? I mean, we live in a world that's designed around the hospital. And moving from hospital-based metrics to population-based metrics is where we're going, right? I mean, the Affordable Care Act is structured around, affordable care organizations and patient-centered medical homes and how to measure care in that way. So our group developed this 30-day readmission measure that's now being used to ascertain, hospital quality. And I can't even tell you the amount of pushback we got, because hospitals hate that measure because it's about the care patients are receiving when they step out of the door and preventing them from coming back in. So, this was very much at the cusp of what was acceptable. I'm not even sure that it was acceptable, but we've advocated for the importance of the hospital as the sort of dominating force in the market around care, their ability to promote care coordination to the physicians within the community and to sort of work on those transitions of care to prevent patients from coming back in. I mean, so that's an example of how we are trying to push into the prevention part, right? So preventing people from coming back in. But the second part of it is population-based metrics. And we're increasingly focused on how to do that and how to do that well. And there's other organizations doing that. But it's much, much more difficult because the data is not as good, right? So when we're talking about hospital care, even though we're limited to administrative claims data, we're on okay ground. But when you're moving into the claims data from a population standpoint, it's just hard to work with. It's huge amounts of data, and it's just less reliable because you have data coming from all different physicians, and so it's a little bit trickier.
And I would also say, and I'm not defending or trying to be neutral about it, but the hospitals are, they get really whipsawed in all of this. They can do better, there's no question about it, but they also have a lot of conflicting interests. I remember I was in New York State government when we finally got hospitals to agree that, and we did it really with fiat, regulatory fiat, that there wasn't going to be any smoking. That was not an easy that was hard, really, really hard. And so the first thing when you say we let no more McDonald's in the hospital is you've got to take a look at the hospital's financial situation, because the McDonald's is in there because it's a moneymaker. It becomes a revenue source like parking and all those kinds of things that help keep a hospital's finances together. And a lot of them, the nonprofits in particular in the United States, are on very, very slim margins these days. I'm not defending it. It is not defensible. But they have these conflicting kinds of demands, including the other one that's interesting is the customer demand. They're doing all the HCAP scores now and been doing that for quite a few years, but some of the things that they're trying to do to keep patients happy have nothing to do with healthcare. It's like valet parking and better food, more tasty food, not necessarily healthier food, but all of those kinds of amenities. A lot of hospitals have gotten very deep into hotel kinds of services to get their HCAP scores up, because they know that patients don't necessarily rank the care based on the outcome, but on what happened when they were there, including did they get the particular pharmaceutical intervention that they wanted. So it's very, very complicated. You're right in terms of, there shouldn't be fast food in the hospitals, but it didn't happen, it kind of happened because of a lot of reasons, both internal and external.
One solution you might want to think about is shifting towards things like Subway, has better choices, obviously, or Taco Bell. Hey, you got beans,
Let me just reassure you, we are not the ones making the decision.
Right, and that's
No, I know, I realize it.
know,
But as thought leaders, you can publish, you can talk about it, you can discuss it, and you're accrediting, so you're obviously in a position of power.
I don't think the Joint Commission has actually commented on McDonald's, but I have to tell, it's not unique to the States. There's a hospital in Malaysia with a big McDonald's inside of it, and Ronald McDonald is in the namaste position. That's the only difference. It's a great photo.
Oh my gosh. Yeah. Well, it's something perhaps you should bring up. I mean, from a leadership perspective and ethical perspective.
I think it's a fair question.
Yeah,
it's a very
that's
fair
all.
question.
Just want to try to push the ethical boundaries here. Part of the purpose, of convening, to get the ideas forward and try to, make some progress here. So anyway, thank you very much.
Thank you.
Just another complexity that occurs to me is, for a lot of the patients that we have at my hospital, at Children's across the street, the families don't have a lot of money, and McDonald's is an affordable choice for them, where even the cafeteria is more expensive, and so you see them bringing in the food from the food court across the way, and it's just financially driven for them. They're already pressed trying to pay for parking, and so that's the meal they can afford. Nir, did you have a comment?
At the end of time, maybe I'll just that doesn't even require kind of an answer from the panel. I'll just mention that one of the intriguing aspects for me of this panel was, so I'm listening to Lisa. Lisa gets results at PIH by being inside the organization and being fully trusted by the organization, and thereby being able to implement the, so we have the kind of closing of the feedback loop. The equivalent of this in the world of not organizations that are in the business of doing good is some of the worst labels. It is Walmart giving itself, oh, we're great, labels. And it's interesting to map. I think it's working really well in some areas. And Paula tells us the experience of being very, very external cup has been maybe working less well than the kind of new trend of working a little more with. Maybe in a hospital world where doctors who have their professional oaths and kind of loyalty to some degree, even independently to patients beyond just financial interests. So it works better in some areas and worse in some areas of industry, and it would be interesting maybe to map how much kind of all this could be exported to other areas, other industries.
All right, well, we have a break now, and then we have our final session.